I hope and I believe all of you are doing well. I hope the audio video is all good, everybody. A quick nod in the chat so that I know that we can proceed with the session. Let me just have a look here. Right, that's great. So today we are going to simplify this topic of nuclear medicine with all the concepts behind it and the tricks also to remember the various nuclear scans, right? So you generally get one question on the nuclear scans or nuclear medicine. And if you ask me, nuclear medicine is an altogether different branch as, versus radiology. Like you have MD in radiology, you have MD in nuclear medicine. So it's an altogether different branch, a 3 years different entire course. But right, in next 1 hour or so, we are trying to learn the most important points that we need to know for our exam, at least, right, from the exam point of view. So, right, let's try to understand it and let's try to remember it as well, right? Understanding, retention, both are equally important. Hi, good evening, everyone. Yes, so I can see Sai Anusha, Ankit, RG, Achan, Nirday, then we have Sonu and everybody here. That's great. Yeah. Rashmi, if you have not done nuclear medicine yet, then you attend this session, right? If you have watched the videos already on the PrepLadder app or anywhere else, you have done it from anywhere else, then you can skip it. If not, then this is going to be like a concise revision of this topic of nuclear medicine for the upcoming FMG exam as well. Okay. Right. All right. So let's start discussing about it. So how is nuclear medicine different from radio diagnosis, and why do we need a nuclear medicine department? What is the role of nuclear medicine department? So to explain it in the best way, try to understand the fact that let's say that you have a patient for whom you are doing ultrasound of thyroid. Right. So in ultrasound and sonography, you can just see the nodules, the number of nodules, the appearance of nodules, whether they are hypoechoic or they are hyperechoic. But you cannot comment on whether these nodules are hypofunctioning or they are hyperfunctioning. So can you tell me that to look for the functioning of these nodules, whether they are hypofunctioning or not? What scan will you do for that to look for the functioning of the thyroid nodules? What do we do? Onyx, I'm sorry, I forgot to share the PDF beforehand. I'll share the PDF, after the session on the Telegram group as well. Okay, no. So what do you do for the thyroid nodules? What is the scan that you do for the thyroid? The activity of thyroid, not the PET scan. What do you do? Yes, guys, what do you do for that? It's a radioactive iodine uptake scan, right? So it is radioactive iodine uptake scan, which is done. So you give the radioactive iodine, and you know that thyroid takes up the iodine. So depending on how much iodine is being taken up by this nodule as compared to the normal thyroid gland, you will compare and you would see that this is hypofunctioning or this is hyperfunctioning. Absolutely right. So you would do a radioactive iodine uptake scan. So this radioactive iodine uptake scan, this is done in the nuclear medicine, right? So I hope this example gives you the clear difference between what is radiology about, radio diagnosis about, and what is nuclear medicine about. When you want to do functional imaging, that is where the role of nuclear medicine comes in. And how does nuclear medicine gives you the functional imaging is by using these radioisotopes, right? So like iodine itself is the radioactive iodine isotope itself is a radioisotope. It is taken up by the thyroid. So it is used for the thyroid scan, right? So similarly, you have this. Yes, this video is definitely for the FMG students as well, right? So remember that in nuclear medicine, it's about functional imaging. We use a radioisotope like we are using radioiodine. So like in radiology, you have X-ray, ultrasound, CT, MRI. What are the various modalities that you have in nuclear medicine department? So in the nuclear medicine department, the modalities that we have is scintigraphy, the nuclear scan, the radioisotope scan, that's the basic scan. Then you have SPECT, and then you have PET, right? So there are three modalities that we have here, right? So you have the nuclear scan, the SPECT, and the PET. Now you tell me that what is the full form of SPECT, guys? SPECT stands for single. What does P stand for? Let me see how many of you get this right or you make a mistake here. SPECT mein, what does P stand for? P. What does P stand for in SPECT? Very good. That's amazing. So you are right there. It is single photon emission computed tomography. Please do not make a mistake here that the I'm sorry. Is my screen visible? Yes, I believe. So it is single photon emission computed tomography. It is not a single positron emission. Please remember this point and do not yeah. So please understand this point that it is single photon emission and not single positron emission CT. Okay, this is very, very important. So like in radiology, you have X-ray as the basic modality and the 3D X-ray is a CT. Similarly, in nuclear medicine, you have scintigraphy as the basic modality and like CT, you have SPECT. So logically thinking, which one will have a better resolution, a scintigraphy or a SPECT? SPECT is the CT, right? So it will have a better resolution as compared to scintigraphy. Okay, it will have a better resolution as compared to scintigraphy. So even on based on this simple concept, you had a question in INI-CET last year, which mentioned about parathyroid. So what imaging will you do for parathyroid? Amongst the options given, you had cysta maybe scintigraphy, or cysta maybe scinti, or cysta maybe SPECT, both given in the options. So when you have a scinti and SPECT both given in the options, remember that SPECT is going to be better resolution imaging. So you will prefer SPECT over scintigraphy. Is this clear with everyone? Right? So remember that scintigraphy is like X-ray. SPECT is like a CT. What makes SPECT three-dimensional is basically multiple gamma cameras are used. The detector used here is a gamma camera. So understand the functioning of nuclear medicine. What do we do is in scintigraphy, you have radioisotope, which is used in scintigraphy. What is the most common radioisotope used in scintigraphy? What is the most common radioisotope used in scintigraphy? Yes, anybody? Very good. Dwarika Abhishek, correct. The most common radioisotope used is technetium 99M. Okay, the metastable form of technetium 99, it is technetium 99M, which is the most common radioisotope used here. This technetium 99M, it emits gamma rays. Okay, remember it emits gamma rays of 140 keV. That is what is used here. And what is the half-life? Suppose you get this question in the exam. What is the half-life of technetium 99M? Is it 6 seconds, 6 minutes, 6 hours, or 6 days? Very good. It is 6 hours, which is the half-life. Understand the point that this is a diagnostic isotope. So you need a half-life which is good enough to complete the scan. 6 seconds, 6 minutes is too short to complete the scan. 6 days is too long. The patient will keep emitting the radiation. So the best answer here, the half-life is going to be 6 hours. Okay, the half-life is going to be 6 hours. Right, there's some issue with the connectivity of the screen, guys. Just bear with it. Right, it is going off in between. Okay, so it is 6 hours, which is the half-life. So what do we do in scintigraphy is you have technetium 99M, which is bound to a ligand. Right, technetium 99M is the radioisotope. It is bound to a ligand and it is given injected in the body, and then it goes into the body. The ligand is what takes the technetium 99M to the target organ. How will technetium 99M realize that I have to go to heart, or I have to go to kidney, I have to go to bones? How will it understand that? So it is bound to a ligand which takes it to the target site. And from there, when it is taken up by the target site, it emits the radiation. And this radiation, which is being emitted by the patient, depending on the uptake, will be measured by the detector. What is the detector used here? The detector used here is a gamma camera. Remember, it's not gamma knife. Another commonly done mistake here. Remember, this is not gamma knife. It is gamma camera, which is the detector which is used here. Gamma camera will capture the photos of the radiation being emitted by the patient. Okay. So in class, remember that this nuclear medicine is functional imaging. Okay. This is functional imaging. Technetium 99M is the most common radioisotope in scintigraphy. You bind it to the ligand, like you have DMSA, DTPA, pertechnate, MDP. These are the ligands. They will take it technetium 99M to the target site. Okay. So this is the basic of nuclear scan. Is everybody clear with that? Yes. right? So that was about scintigraphy. SPECT is nothing but just like scintigraphy, but it's a three-dimensional scintigraphy. It has the multiple gamma cameras which are there. So it gives you a rotating gamma camera, which gives you the better imaging. And then comes the PET. What is PET for? P for? What is P for in PET? In PET, P is positron emission tomography. Okay. In PET, P is for positron emission tomography. Again, remember that this is tomography. This is not therapy. PET is a diagnostic scan, not a therapeutic scan. Okay. So what is the radioisotope which is used in PET? Do we use this technetium-99m in PET? Do we use this technetium-99m in PET? Very good. It is, right? So Abhishek knows it all about nuclear medicine. It is 18F fluorine, which is 18F is used. Why not? So, when you talk about PETs, we most commonly talk about FDG PET. FDG PET, right? What does F stand for? F stands for F18. What does DG stand for? Deoxyglucose. Okay, DG stands for deoxyglucose. So out of that, this F18 is the radioisotope. Deoxyglucose is the ligand which is used in PET scan. The most common ligand used in PET scan is deoxyglucose. F18 is the radioisotope used. Why do I use F18? Why do I not use technetium-99m in PET scan? Why is there this difference? In scintigraphy, you are using technetium-99m. But in PET scan, you are not using technetium-99m. Why? Why do you want F18 only? Because this F18 is a positron emitter. Okay, it's a positron emitter. It emits positron, and that is what I need in PET scan. I need a positron emitter. It's a positron emission tomography. Technetium-99m emits gamma rays and not positron. So that is why we do not use technetium-99m. Next is, why do we use deoxyglucose as the most common ligand? Why? Because what is the most common indication of doing PET scan? PET scan is basically done for cancer staging to look for where all the cancer has spread in the body. And you know that the cancer cells, as compared to normal cells, they take up more glucose. What is this effect called as? This effect is called as Warburg effect. Okay, this effect is called as Warburg effect. And so cancer cells take up more glucose. So you use the ligand also, which is deoxyglucose. Why deoxyglucose? Because this deoxyglucose, when gets converted to deoxyglucose phosphate, right, it gets trapped and does not get metabolized further. So it gets trapped in the cells and it will be picked up by the detector, right? So remember that the most common ligand used here is deoxyglucose. FDG PET is the most common here. Okay. So the ligand is DG. And just remember the name of the principle used in PET scan. What is the name of the principle used in PET scan? The principle used in PET scan, just remember the name, annihilation coincidence circuit. Okay, annihilation coincidence circuit is the name of the principle which is used in PET scan. I'm not going into details of that now, but just remember the name, annihilation coincidence circuit. Now, the next question is, what is the half-life of F18? Is it 100 seconds, 100 minutes, 100 hours, 100 days? What will be the answer for this now? I've told you how to guess the half-life. 100 minutes, 100 seconds, 100 hours, 100 days. Correct. It's going to be 100 minutes. Why? Now, do not say that आपने बोला था कि hours में होगा, seconds, minutes बहुत कम है. Remember, 100 hours is like more than 4 days. So 100 minutes, which is like between 2 hours, around 2 hours approximately, that is good enough to complete the scan. Even this has been asked as a previous question. Half-life of F18 is 100 to 110 minutes, right? And what test would you like to do before doing the PET scan? What test will you do before doing the PET scan? Because in PET scan, you are using deoxyglucose. Suppose there's a patient who has high glucose levels, high blood glucose levels. There is high blood glucose, there is deoxyglucose. The high blood glucose is what will be taken up by the cancer cells rather than the deoxyglucose. So we will get false negative results, right? So the blood glucose levels need to be tested before doing PET scan. Patient is asked for fasting so that the glucose levels are not high. Absolutely right. So it is the glucose levels that need to be tested, right? So coming to some important nuclear scans that you should know here. right? If the screen allows us. Yes. Right. So remember that for the kidney, the scans that we have is DMSA, DTPA, and MAC3. These are the names of the scans that we have. The trick to remember is, remember DMSA actually is for dimercaptosuccinic acid, but for a mnemonic, the trick to remember is, remember M for morphology, okay? M for morphology and S for scarring, okay? M for morphology and S for scarring. So it helps you to see the renal morphology, the scarring in the kidney. That is what it helps you to see. So even if you want to see ectopic kidney, right, this is taken up by the kidney, you'll be able to see the ectopic kidney. In which condition do you see scarring in the kidney? For example, in a patient with vesico-ureteric reflux, recurrent, the reflux leads to the scarring in the kidney. So there you want to see the scar because of the reflux. So you would do a DMSA scan. But please remember, read the question carefully. Is the question asking, I want to see the VUR scar, the renal scar, or I want to see, the question is, what is the investigation of choice for vesico-ureteric reflux? If that is the question, then what will be the answer in that case? What is the investigation of choice for vesico-ureteric reflux? Yes, very good, Pooja. Absolutely right. It is MCU. Because micturating cystourethrogram, when the bladder is contracting, when the bladder is micturating, that is when you would see the reflux happening. Okay, the contrast going backwards into the ureter and the kidney, right? So remember, it is micturating cystourethrogram, which is helping you to diagnose the VUR. It is DMSA scan, which is helping you to see the scar because of VUR. Okay, important, two different questions. For DTPA, remember the trick is P for physiology. Physiology means the function of the kidney, right? So it's a functional scan. So what function of the kidney does it tell you? The DTPA tells you the GFR, right? It tells you the GFR because this DTPA is excreted by GFR only, not by the tubular secretion. So it will help you to estimate the GFR. Next question is, can you tell me the gold standard investigation for GFR? What is the gold standard for measuring the GFR? The gold standard is inulin clearance test. Okay, the gold standard is inulin clearance test, which is the gold standard. Okay, so remember that DTPA is for GFR. MAG3 is like a magnificent scan, helping you to see the overall function of the kidney, right? That is glomerular also plus tubular also. That is where MAG3 helps. Okay, that is where MAG3 helps. So remember the names of the scans. You have DMSA, DTPA, and MAC3. Okay, DMSA, DTPA, and MAC3. So this is about the renal scans. Okay, this is about the renal scans that we need to know here. Okay, clear with everyone? It is asking me again and again to trust this device, but it's already trusted, right? Okay. All right, talking about the cardiac scans, everyone. So cardiac perfusion that and MI. When you want to see cardiac myocardial ischemia, okay, you have myocardial ischemia, you have myocardial infarct. What is a scan which is done for myocardial ischemia? That is the thallium scan. Okay, that is the thallium scan which is done for myocardial ischemia, right? What will you see if there's myocardial ischemia is there's going to be a reversible defect. Okay, there's a reversible defect which is there. There is no uptake where there is ischemia. You ask the patient to exercise, you will see this defect. You ask the patient to rest, this defect will become normal. So reversible defect on thallium scan is suggestive of ischemia. Is this clear with everyone? Yeah, you would see the cold spot because there is decreased perfusion. Okay, because there is decreased perfusion, you would see a cold scan, right? A cold spot there, basically. Coming to MI, very, very important question. In which scan do you see hotspot in MI? MI gives a hotspot with which scan? There is specific scan for where you get a hotspot in MI. Remember, it is a pyrophosphate scan. what we think is कि ये MI है, infarct है, मतलब dead tissue है, तो uptake नहीं होना चाहिए. So we should get a cold spot. No uptake means a cold spot. More uptake means a hot spot, right? So here it is the reverse. It's a dead tissue, but there is hot spot. Remember, this is seen with pyrophosphate. This pyrophosphate is taken up by the dead tissue and it does not get metabolized, right? So it accumulates there. So you can remember this as pyre is like fire. Hot like fire is pyre. So this is MI is pyrophosphate scan showing a hot spot. Next to that you have is ejection fraction. What is the scan that you do to measure the ejection fraction, which is basically the function of the left ventricle? Left ventricle का function है कि eject करो blood, right? Ejection fraction के लिए कौन सा scan करते हैं? This is the previous FMGE exam question as well. It is MUGA scan. Okay, MUGA basically stands for multiple gated acquisition. Okay, multi-gated acquisition. MUGA is what you have here. You use radio labeled RBCs here. This is for left ventricular function. Okay, for left ventricular function, you have MUGA scan, the nuclear scan. Going to the bone scan, what do you use for bone scan? Which radioisotope do you use for bone scan? The same, that is technetium-99m. And what is the ligand that you use here? Tell me, what drug do you use in osteoporosis? What is the drug used in osteoporosis? What drug do we use in osteoporosis? Bisphosphonates, because that is taken up by the bones, right? So similarly, you have diphosphonate scan, which is done for bones. This diphosphonate is taken up by the bones, so you have diphosphonate scan. MDP, HMDP, HEDP. So all the DP is diphosphonate. Methylene diphosphonate, hydroxymethylene diphosphonate. Remember, it is diphosphonate scan, which is done for bones. Okay, MDP scan is for bones. Okay, that is how you remember. And where do you get a hot spot in the bone scan? Where do you get a hot spot in the bone scan? Hot spot is seen when there is new bone formation. Okay, hot spot is seen when there is new bone formation. Like, remember, so please understand this fact that bone scan positive hot spot does not mean that it is metastasis only, right? There are multiple causes. Wherever there is new bone formation, like in fracture, you have new bone callus formation. In osteomyelitis, there is new periosteal reaction which is happening. Then in metastasis, tell me what metastasis will this bone scan show? Will it show the blastic, lytic, both? Blastic or lytic? New bone is forming with the blastic metastasis. So it is blastic mets only, not the lytic mets. And that is why this bone scan is really not a very good scan for the bone mets, because it does not pick up the lytic metastasis. Okay, it does not pick up the lytic metastasis. So what will be a better investigation? What will be a better investigation for bone mets? Because bone scan is not picking up the lytic mets. So you have either PET scan, right? You have PET scan. A specialized PET scan also can be done for the bones. Somebody had mentioned that the sodium fluoride PET. NAF, that is the sodium fluoride PET, is specific for the sodium fluoride PET is specific for the bones. Okay, or you can do MRI as well. Okay, MRI can also be done, or whole body MRI can be done to pick up these mets. Okay, even the lytic mets can be picked up there. So remember that in which conditions in the bones will you see the cold spot? Cold spot means no uptake, no new bone formation. Remember, it is multiple myeloma, one of the causes. Very important question. In multiple myeloma, do you have new bone formation? No. How are the alkaline phosphatase levels in multiple myeloma, guys? How is the alkaline phosphatase levels? It has normal alkaline phosphatase. Very important question to be remembered, right? In multiple myeloma, alkaline phosphatase is normal. There is no new bone formation, right? It is just the lytic lesions, no new bone formation. So there is cold spot. So you get cold spot in multiple myeloma. Okay. So tell me that which is other bone condition where you have only alkaline phosphatase very high, calcium and phosphorus is normal. Only alkaline phosphatase, which is very high, and the calcium and phosphorus is normal. Very good, Nirday. Absolutely right. It is Paget's, right? Paget's has high alkaline phosphatase. Rashmi, never ever forget that. In osteoporosis, everything is normal. Calcium, phosphorus, alkaline phosphatase, everything is normal in osteoporosis. And that is why, how do you diagnose osteoporosis? How do you diagnose osteoporosis then? Very good, Anshika. Correct. It is diagnosed by DEXA, right? So that is DEXA, which helps you to measure the bone mineral density. Remember, bone scan is different from DEXA scan. Please do not confuse the two, right? Bone scan is not the DEXA scan. DEXA scan is for bone mineral density, which helps you to diagnose osteoporosis, right? And this, which we are talking about, this is the bone scan, okay? The nuclear scan. Coming to next one, what is the nuclear scan for biliary tract? For biliary tract, you have HIDA. Okay, HIDA, I'm sure you must have read in pediatrics as well. कहाँ पढ़ते हो pediatrics में HIDA scan का role? Where do you read about HIDA in pediatrics? Yes. In which condition do we read? Very good, Ritesh. Correct. It is biliary atresia, right? Biliary atresia. Biliary tract का patency देखना है या leak भी देखना है तो आप HIDA scan कर सकते हो. HIDA is basically a tracer which is taken up by the biliary tract. So you would see it coming into the gallbladder, the bile duct, and finally it will go into the duodenum. So if you're seeing it going everywhere, right? Gallbladder, bile duct, duodenum, then you know that it is a patent biliary tract. There is no obstruction anywhere. So it's not a biliary atresia, right? How does it help you to identify bile leakage? You would see this HIDA going out of the biliary tract into the locations outside the biliary tract, right? Very good. It is gold standard investigation for cholecystitis, correct, Gopinath? But suppose if you have a patient of cholecystitis, what is the first investigation you do? What is the investigation of choice? Do you do HIDA in all the patients of cholecystitis? What is the investigation of choice for cholecystitis? Very good. That is USG, right? That is USG. But suppose if you do HIDA in a patient of cholecystitis, what do you see in a patient of cholecystitis? Acute cholecystitis on HIDA scan. What findings do you see? Yes. Very good, Nidhi. Absolutely right. It is GB not visible. Because what happens? Why does a patient develop acute cholecystitis? Is because of the gallbladder getting obstructed due to any reason. It is a stone or any other reason. The gallbladder is not able to empty. It gets distended. It gets inflamed, right? It gets edematous. So when this is obstructed, even the HIDA will not be able to go into the gallbladder. So you will not be able to see the gallbladder. So you would see that gallbladder is not visualized in acute cholecystitis. And on the other hand, the liver, which is adjacent to this gallbladder, that shows the hot rim sign or the hepatic rim sign or the hot rim sign is what you see here. The adjacent liver also gets inflamed. Right, very good, Gopinath. You get this rim sign, the hot rim or the hepatic rim sign. Minhaj strawberry gallbladder is cholesterosis, right, which gives you comet tail sign on ultrasound. Okay, so that is cholesterosis is strawberry gallbladder. Right, so this is about your HIDA. Similar to HIDA, you have the SIDA, PPDA. So all the EDA scans, immunodiacetic acid, right? So EDA stands for immunodiacetic acid, which is for the biliary tract. Okay, this is for the biliary tract. Right, going to some other scans, the names of some other scans here. For parathyroid adenoma, what is the scan? This is like the very favorite question in nuclear medicine. If you ask me that, which is that one question that we should definitely know? It is parathyroid adenoma ke liye we do the cysta-MeB scan. Sometimes in the question, they might just mention MeB, right? Rather than cysta-MeB. Okay, it is cysta-MeB scan. And cysta-MeB SPECT is going to be better than cysta-MeB scintigraphy because SPECT has a better resolution, right? So remember that they do not ask you the question directly, right? You know, what is the scan that you do for parathyroid adenoma? Rather, they give you the clinical features here in parathyroid adenoma, hyperparathyroidism. What are the clinical features? Stones, bones, groans, moans, right? It is stones, bones, groans, moans. There are renal stones, bone pain, abdominal pain, and psychiatric features. So when you have this constellation of features, this has been asked in one of the recent FMGE exam as well with the clinical features. This is parathyroid adenoma and you need to do cysta-MeB scan. Okay. So that is what you do for parathyroid. Clear with everyone? What is the scan for Meckel's diverticulum? Okay, first of all, tell me a clinical question that if there is Meckel's diverticulitis, patient presents with pain where? In what quadrant of the abdomen does the patient have pain? Where is the pain when there is Meckel's diverticulitis, the Meckel's diverticulum getting inflamed? Yes, very good. It is right iliac fossa, RIF, similar to appendicitis. So remember that Meckel's diverticulitis clinically presents very similar to appendicitis with RIF, right? Because it's in the right iliac fossa. Ilium क्या होता है? ये diverticulum, Meckel's diverticulum. It's a true diverticulum, right? It is remnant of vitellointestinal duct, right? So remember that Meckel's diverticulum for MEC, the trick to remember is MEC is TEC, right? Nirday has already mentioned MEC is TEC. So remember TEC is per technate scan. You have technetium 99 per technate scan, which is done for Meckel's diverticulum. MEC is TEC. Okay, MEC is TEC per technate scan is done for Meckel's. Why per technate scan is done? The concept here is this per technate is picked up by the normal gastric mucosa as well. So suppose if this is the abdomen, you have the stomach here picking up this per technate, and you know that in Meckel's you have rule of two, right? Which are the two ectopic tissue that you get in Meckel's? Gastric and pancreatic. So if the Meckel's is having ectopic gastric tissue, even that will show the uptake of per technate, right? So uptake of per technate in the right iliac fossa will basically tell you it is ectopic gastric tissue, and you are then diagnosing Meckel's based on that. But remember that not all Meckel's will be positive, because if it does not have ectopic gastric tissue, it will not be positive. Okay. So that is about this concept here about Meckel's. Going to next one, pheochromocytoma, which is a tumor of adrenal cortex or medulla. Pheochromocytoma के important points. It is a tumor of adrenal medulla, right? Adrenal medulla जहाँ से catecholamines आते हैं. So basically here there will be increased catecholamines, right? So what is the screening test that you do for pheochromocytoma? देखो डायरेक्टली आप MIBG स्कैन नहीं करते हो. When you are suspecting pheochromocytoma based on the clinical features of the patient, what are the clinical features in pheochromocytoma? Because of increased catecholamines, sympathetic overactivation, there will be hypertension, palpitations, headache, sweating, right? Diaphoresis. These are the classical symptoms which are given here. Episodic hypertension, palpitations. Whenever you see this in any question, it is pheochromocytoma, right? So first thing is measuring, absolutely right, the urinary metanephrines, VMA levels, which are produced by this metabolism of catecholamines, they will be increased. So the screening test is first the urinary metanephrines and the VMA levels. They will be increased. Now, once they are increased, you know that, okay, so there is a pheochromocytoma. Does pheochromocytoma always occur in the adrenal medulla, or can it occur anywhere else apart from adrenal? Are all the pheochromocytomas in the adrenal medulla itself? Yes or no? Yes. No. There can be extra adrenal as well. Kitne percent extra adrenal होते हैं? Correct. So in pheochromocytoma, you have the rule of 10. This has also been asked in the exam. Rule of 10 for pheochromocytoma. 10% are extra adrenal. Right? So 90% adrenal, 10% extra adrenal, extra adrenal. Pheochromocytoma is your paraganglioma. Right? So remember that to see for the adrenal pheochromocytoma, क्योंकि most common site वही है, तो पहले हम करते हैं adrenal का MRI. ठीक है कि एमआरआई में लाइट बल्ब साइन दिखती है T2 पे, तो ये फियोक्रोमोसाइटोमा है. अगर एड्रिनल में नहीं दिख रहा है पर यूरिनरी मेटानेफ्रिन्स हाई है, that means you are suspecting extra adrenal pheochromocytoma, and that is where the role of nuclear medicine comes in, because it will scan the entire body. So wherever there is this extra adrenal pheochromocytoma, that will be picked up by this MIBG scan. So remember, we do this MIBG scan for pheochromocytoma, extra adrenal pheochromocytoma, MIBG. Because this MIBG is incorporated during catecholamine synthesis. So if wherever there's the synthesis happening, it will go there, right? So it is MIBG scan. What PET scan, specific PET scan can we do for this? Remember catecholamines, dopamine, norepinephrine, epinephrine. So dopamine, remember we have something called as dopapet. Dopapet, which is done for pheochromocytoma. Dopapet, dopamine, norepinephrine, right? So remember dopapet is done for pheochromocytoma. Okay, clear with everyone? Going to next one for neuroendocrine tumor. Neuroendocrine tumor. Remember, like endocrine, जैसे endocrine से related, somatostatin, octreotide. This is what you have. So you have DOTA-TOC, DOTA-NOC, PET. Okay, DOTA-TOC, DOTA-NOC, PET. TOC and NOC. The OC here basically stands for octreotide, right? Which acts on somatostatin receptor. Okay, which acts on somatostatin receptor. So remember it as endocrine, somatostatin, octreotide. So DOTA, TOC, DOTA, NOC, PET. Or you have somatostatin receptor scintigraphy also. SRS, the somatostatin receptor scintigraphy, DOTA, TOC, DOTA, NOC, which is done for neuroendocrine tumor. Okay, which is done for neuroendocrine tumor. Thyroid scan, which is radioactive iodine uptake scan, right? Radioactive iodine uptake scan. What is the ideal radioisotope to be used for this? For radioactive iodine uptake scan, it is iodine 123. Why iodine 123 is the ideal? Avinash, maybe an MIBG is different. Maybe is for parathyroid, MIBG is for pheochromocytoma. Right? Maybe is parathyroid, MIBG is pheochromocytoma. Right. Iodine 123 is the ideal. Why 123 is the ideal one? Because logically thinking, any diagnostic radioactive isotope should have this half-life in hours. And this 123, 1 and 3, the first and the last number, it has the half-life in 13 hours. So the half-life is good enough. Okay. Right. So remember, the half-life is 13 hours. It is not in days, so it is ideal. But when this is not available, the next that we use is iodine 131. Like in India, we may do that, right? Using iodine 131. And look at this thyroid scan. Do you see diffuse hot spot or diffuse cold spot? What are you seeing in the thyroid? So this is the thyroid showing diffuse black appearance. Black in nuclear scan is hotspot. So this is basically diffuse increased uptake in thyroid. In what condition do you see the thyroid is very active? Thyrotoxicosis, that is Graves' disease. Okay, Graves, thyrotoxicosis, diffuse increased uptake. Where do you see diffuse decreased uptake? In thyroiditis. जहाँ पे पूरा thyroid burnout हो चुका है, there is hardly any uptake. Thyroiditis has diffuse decreased uptake. Graves has diffuse increased uptake, right? And one of the recent last time FMGE exam question, PMSA PET scan. What is this done for? What is this PMSA PET done for? Yes. What is PMSA for? PMSA PET scan. Remember, this is prostate membrane specific antigen. Okay, this is for prostate cancer. Okay, PMSA is done for prostate. It has been asked in the recent FMG exam. Next question, that HMPAO SPECT. What is HMPAO SPECT done for? What is HMPAO SPECT done for? Yeah, HMPAO SPECT is done for cerebral perfusion. Okay, remember that it is done for cerebral perfusion. Brain का perfusion देखने के लिए जब brain death होगा तो तब यहाँ पे cerebral perfusion नहीं होगा, uptake नहीं होगा. So remember, PMSA is for prostate and this is for cerebral perfusion. Very good. This is important. Okay, right. So going to the last point here regarding iodine isotopes, iodine 123, iodine 125, iodine 131. Okay, these are the artificially produced iodine isotopes. Natural iodine is not radioactive. So first, let's try to understand their roles and also to understand their basically the half-lives. 123 is ideal for diagnosis. 125 is used as a brachytherapy implant, right? So which is used as brachytherapy implant? It is iodine 125. Commonly used in which cancer? This is commonly used in prostate cancer. Okay. Used for diagnostic ideal is 123. Used for ablation when the thyroid is overactive, ablation करना है graves में जैसे तो iodine 131. Right? So out of this, which is the ideal diagnostic? This is diagnostic. This is for treatment. This is for treatment. So logically thinking, which one will have a shorter half-life? The one which is diagnostic, that is iodine 123. Right? So this will, what will have the half-life in hours. Rest will have the half-life in days and days. Okay, that is how you remember कि किसका hours है और किसका days है. 123 diagnosis वाला है तो छोटा half-life, right? We do not want radiation for long. So this is going to be in hours. This is going to be in days. This is going to be in days. For 123, it is first and last number 13 hours. For 125, it is 12 into 5. 125, that is 60 days. For 131, 1 plus 3 plus 1 plus 3. That makes it how many days? That makes it 8 days. 1 plus 3 plus 1 plus 3. I hope you've done the maths. It is 8. Right? So it is 8 days, which is for iodine 131. Okay, this is 8 days. So this is how you remember. And another important question, this iodine 131 that is used for ablation, its therapeutic effect is due to which rays? Is iodine 131 is what emitter? First of all, tell me this iodine 131 is what emitter? Alpha, beta, gamma, what rays does it emit? Iodine 131 emits beta plus gamma rays. Okay. It is not a pure beta emitter. It is beta plus gamma. Out of that, the therapeutic effect is because of beta or gamma. The therapeutic effect is because of beta rays, not the gamma rays. Okay. Gamma जो है वो body से बाहर चले जाएंगे. The penetration is high. Beta staying in the body and doing the ablation. उनका penetration कम है. They stay in the body. Right? So important that the therapeutic effect is because of beta rays, not the gamma rays. Okay, it is beta rays and not the gamma rays. Right? Is this clear with everyone? Right, so that was about basically about nuclear medicine, where we have understood the concept of what is nuclear medicine, how is it different from radiodiagnosis. To understand that, it's a functional scan which uses a radioisotope with a ligand. So does it have radiation? All the nuclear scans will have radiation present because you are using radioisotope emitting the radiation. Then we have looked at the various modalities in nuclear medicine, scintigraphy, SPECT, and PET. Right, that is what we have learned about. We have learned about the names of the various nuclear scans depending on the organ that we want to image, right? And then we have had a look at the iodine isotopes as well. Okay, iodine isotopes as well. So this is what is the most important stuff in nuclear medicine that you need to know for your exams. Right, this covers your majority of your basically the stuff. Okay. No, right. So HMPAO, whether it is SPECT or you are combining with technetium, right? It's the same. So you just have to remember that this HMPAO is basically taken up by the brain. So whether it's like seizures, तो वहाँ पे जहाँ पे seizure focus है वहाँ पे ज़्यादा uptake दिखेगा. Alzheimer's, less active area वहाँ पे कम uptake दिखेगा. So the basic concept to be understood that this HMPAO is basically for brain. Okay, that is what is the concept there. Yes, clear with everyone? Gopinath, though I do not know the actual, the answer to this, but based on your question and the logic that I can think, technetium pertechnate is basically taken up by thyroid, gastric mucosa, salivary glands. It is not taken up by the lungs, right? So as far as I know, I haven't read about pertechnate being used for lung cancer. Right? So yes, that was about the nuclear medicine, the score booster session that we had for today, guys. Revise it well. Make your 1-2 page notes for nuclear medicine out of this session and keep revising it. Covers your majority of the stuff of nuclear medicine, right? I hope you have found this session useful. Right, stay tuned for more such sessions coming up, the score booster sessions that we are conducting on the PrepLadder YouTube channel. Right, so if you're subscribed to the channel and you have the bell icon on, you'll get the notifications for all the sessions. Make the best of all the sessions that are being provided to you. Okay, thank you so much, Rashmi, and everybody here. Yes, goodbye, take care, and see you again soon. Thank you so much.